This presentation is on data, analytics, and business intelligence, clinical intelligence, BI/CI. The objectives for this presentation: appreciate the myriad and competing sources for healthcare data. Understand the size and exponential growth in healthcare data. Describe the complexities and challenges for healthcare data. Identify methods and priorities that healthcare may adopt to leverage both clinical and business data. Appreciate the historical foundations of healthcare BI, business intelligence, and CI, clinical intelligence. Understand the sources and the evolution of data. Describe the myriad stakeholders who need BI and CI information to perform their job in the healthcare arena. Identify methods for receiving, organizing, storing, mining, and formatting data for BI and CI purposes. The study of healthcare data has two dimensions. In the first dimension, we're looking at technical knowledge. You need highly skilled personnel when you're dealing with technical knowledge. If you have a poor infrastructure, this is going to prevent you from realizing the true utility of the data from being realized. Your second dimension is the need to imaginatively understand data and its properties for analysis. This dimension is not technical, or is not as technical as the first dimension. But we need this for organizational growth. So in this dimension, you have non-technical participants in your BI and CI. And it contributes to the translation of data for technical professionals into the form needed for analytics. So these two dimensions have to work together, because you want the end result to be that utilization of that BI and CI data. Now, when we look at healthcare, we see that it is adopting new technologies in the care delivery methods, and this is in turn increasing the volumes of data farther than we've ever imagined, or larger than we've ever imagined. So what we want to do is to be able to leverage that data so that we can provide more affordable and quality care. So how are we defining data? We will define data as base-level computer information that may consist of numerical or word elements, facts, values, or combinations of stored information, and from which knowledge is derived and decision-making may be made better and more logical. So implicit to this definition is that the message that data can be valuable. We want to have an industry in which we can make better decisions based on that data. Data has always had value, but due to some of the technologies that have recently accelerated and that we've recently adopted, there has been massive changes in how data is sourced, assimilated, integrated, stored, and mined as assets. And it can significantly and positively affect our healthcare industry. Healthcare data may take varying forms. It can be simple, such as patient demographics, or it could be complex in terms of when we look at things like clinical data, such as lab results. It can be confusing and disparate in nature. The vast sums of data that we've collected over the years in healthcare have principally served the internal organization's purposes, and those are usually separate from other healthcare organizations. However, with a new intense focus on lowering healthcare costs, it has made us as a healthcare industry look introspectively into how we may use that data in order to perform better. When we have better data, we can measure quality improvements more effectively, and with better data, we can do things that we previously thought was impossible or was not imaginable. There are many major companies that have an expertise in massive data sets, like mobile communications, and they can provide us with previously unavailable data storage and access methods. But this can be complicated by different federal and state regulations that we have to comply with, such as HIPAA. When we compare ourselves with other industries, we really do have our fair share of challenges. What we find in our environment is that our organizations in healthcare, we do the same things differently for the most part. So we all have the same functions, but we carry out those functions differently. We also see a lot of significant overlap and commonality in our data. And we also see our clinical data being siloed, and we talk about that sort of enveloped in its own cocoon, and it's not being communicated between other software systems. So the current state of our data within healthcare is pretty problematic. But when we look at data sources, in a previous presentation, we kind of addressed the fact that healthcare had a large portion, or took a large portion of the United States GDP. As a matter of fact, we mentioned that in 2011, the GDP was approximately $17.6 trillion, and healthcare was approximately 18% of that GDP. That segment, the healthcare segment, is growing proportionately faster than other larger segments of the U.S. economy. Furthermore, they forecasted that by 2020, it will represent 20% of the GDP. Along with these statistics, the data generated and the data necessary for us to operate the U.S. healthcare industry is proportionally outpacing other industries, and there's a lot of different reasons for that. We mentioned a couple already. When we look at data for healthcare, historically, most of that focus in terms of healthcare data was on information in the revenue cycle. When I talk about revenue cycle, I'm referring to the billing and the claims situation or systems that we use. And it only had small portions of clinical data involved with that. Then when we look at the Affordable Care Act, under the provisions of that act, The economic risk that came along with implementing EHR systems was rebalanced due to the financial incentives that were being provided to providers to implement those EHR systems. When we look in healthcare today, hundreds of discrete revenue cycle and health record operational systems or data sources are being used by payers, your hospitals, physician groups, your clinics, other provider settings. You may see small, some systems being very small, maybe used in a single department or a specific application in a silo. You also can see at the same time enterprise systems that will produce large volumes of data, and they communicate that data to third parties like insurance companies and governmental agencies and others, as well as retain some of that information for their internal use. And these very different data sources, basically when I talk about data sources, places from which that data comes from, may have applications for both clinical or business processes and analysis. Some of your most significant sources of healthcare data comes from your clinical area. You have transactional and operations, payers, third party, external areas, your government. So when we're looking at your clinical area, what are we looking at in terms of a data source? Well, you got your electronic health records, your electronic medical records, your personal health records, which are data sources. You also have your image management system, PACS, those things that store your x-rays and PET scans and so forth, would be under your clinical. You got case management systems, disease management systems. You have monitoring systems, like in your ICU, that maybe monitor your vital signs or something. You got lab results. These are all data sources under your clinical area. Under your transactional operations as being a data source, you got your hospital information system, like in your admissions department or in your emergency room. You got hospital departmental systems, like in your radiology or your pharmacy. You got your materials management, supplies, cost accounting systems. You got your physician practice systems. You'll hear those called PMSs. Then, of course, we mentioned your revenue cycle process also is a source of data when you're generating those claims. You also have patient accounting, your billing systems for your different healthcare settings. When we're looking at payers, you got your insurance company, and payer claims, contracting systems, claims adjudication, those types of things. Other third parties you might look at is for entities who do research. That would be sources of data, like universities, or if they're doing some type of human research or animal research when it comes to things like medication, clinical trials, surveys, or patient surveys, staff surveys. This is all some data. When you look externally, you got internet resources, you got your registries, your statistical information, risk, industry reporting, like when we're looking at benchmarks, maybe you're doing some type of quality improvement effort, and you're looking at benchmarks, scorecards, report cards, those types of things. You have cellular devices. When you look at government, it's a data source. You have your government programs like your CMS, your Medicaid, TRICARE, which is military, your Veterans Health Administration. All of those things will fall under Medicaid. All those fall under your government. And these are significant, and they have a lot of data from these sources. In this illustration, it just kind of points to like what we were talking about, an enterprise system, how it produces a large volume of data, and they can communicate those to different parties like the insurance companies, governmental agencies, and so forth. And so this is basically just a illustration of your organization chart for the health plan through the Democrats that we have, and it kind of shows all those stakeholders or those people who share that data and where that data flows and who uses it and that kind of thing. So you can take a look at that. But it just shows how an enterprise system will generate large volumes of data. You see all those different pieces and components within that health plan, who has to share information, where that information has to go, come from, produce, or generate, and so forth. So there are principal participants in creating healthcare data, and that sets the stage for understanding the kinds of data sources that will be required. So when we're looking at those principal participants, those are groups such as your providers, your hospitals, hospital systems, your outpatient type facilities, your third-party payers, the government, home health, your pharmaceutical companies, research centers, public health organizations. All of these will be considered principal participants in creating healthcare data. All right, and so we also, as I mentioned, need to understand what kind of data sources that they require to do their job. And basically, they are interrelated. However, although they're interrelated, it's still very complex. And through these, as they function, there are vast sums of information that's being generated and stored so that they can do their job. It's actually quite staggering when you think about the magnitude and growth of the types and volume of data that's being generated in this system. However, no matter how much data we have, good data is going to be, we got to have good data because that's going to be essential in making clinical decisions for patients. It can even save their lives. And so when we think about that and we compare it to other industries, we actually have a unique situation in that it's essentially important, it's significantly important, because if we make inaccurate decisions using that data, there are implications or potential implications for patient mortality. In other words, it can mean life or death for a patient. Now, something else pertinent to our discussion on data is the terms velocity, volume, and variety. These concepts are very important when we're looking at data, and they're really not exclusive to just healthcare. These terms are used in other industries as well throughout the world. Now, when we talk about velocity, velocity suggests that data has momentum, and it is accelerating through increased applications and consumer and business uses, and it's growing virtually exponentially. All right? When you just think about all the cellular technology that's available through people's phones and the internet, we can see how this is very true in that data actually does have momentum. Now, when we talk about volume suggests similar exponential growth of accessible and seemingly necessary data. Through these technologies and applications, we see increasing amounts of data in healthcare. So there is an exponential growth in terms of volume. And as we look into the future, we pretty much see one that is going to see even larger volumes of data. When we talk about the term variety, variety suggests that data are associated with and will continue to take on seemingly limitless descriptions. So data pretty much we need it for different types of uses. So just across different functionalities, like cellular devices, for example, it serves up various health data. When we're looking in terms of healthcare, it can give you information in all types of areas. In concert with the notion that these 3 V's have a significant impact on healthcare, there are 3 types of software applications and technologies that also seemingly will have a significant impact on improving healthcare. And those 3 areas are, in terms of applications, are imaging, your EHR, EMR systems, and your mobile communications and devices. Let's look at imaging. There is an expanding use of imaging. In fact, more and more test results are taking the form of digital images in healthcare. When we talk about digital images, it could be pictures of X-rays or different things like that, and pictures that kind of help provide further clarification or information on maybe some reports in a medical record. For instance, say the physician has some biopsy results. They may attach a picture to the written pathology report. And so that digital image is going to be more precise than just having that pathology report in hand. It's going to better leverage that physician's time. It has portability. Your retrieval is more convenient. And it just gives the physician a better edge in terms of quality decision making. Say if he had that digital image to accompany that report. There is pretty much a direct correlation between enhanced imaging technology and an exponential increase in data requirements. So although digital imaging improves our decision making and quality outcomes, it also is going to require larger data requirements. And as we see the technology enhanced, and we have images that are more granular, are better, then there is going to be even a greater need, or greater data volume than we had in previously. The other we looked at in terms of software application with significant impact was your EHR, electronic health records, and your electronic medical record system. It has a tremendous importance, and it has been a proliferation of these types of systems due to that American Recovery and Reinvestment Act of 2009, in which the HITECH Act is a subset of that act, where they have given financial incentives to eligible providers to implement or embrace these EHRs and these EMRs, right? And so along with those, those systems contain an incredible amount of data. They're easy, fast, and quick retrieval to relevant situations. In terms of your patient, it's going to produce a highly desirable result. However, it's going to come at the price of expensive clinician data entry and large storage amounts. All right, so we're seeing a threaded theme here with as these technologies come about, they are improving our processes and outcomes. However, they are requiring, they generate larger amounts of data, and therefore, as a result, we have larger storage requirements for that data. The third application in technology was mobile communications and devices. At this point, we are in the early stages of what we call mobile health, or HIM health. There's a frenzy of development and idea promotion around the propagation of these types of applications that are focusing on enhanced communication by using cellular devices. That includes personal health management, diagnostic capabilities, and so forth. With that, there's a lot of data generation in terms of mobile communications and devices. We are entering some type of Star Trek-like environment, as a matter of fact, with all these different capabilities. The key point here is that the development in these three areas, your imaging, your EMR systems, your mobile communications and devices, they are more likely to be sustainable. And we're going to see, as we have already up to this point, very big environmental and cultural changes due to these technologies. We see that our consumers, they are demanding more responsiveness in terms of communicating with them information about their health care. These type of demands actually will put strains on our traditional structures, and so therefore we need to find new ways of handling this situation with the increased amount of data and information that's being needed. Providers are sort of struggling to manage the consequences of making all this data accessible to consumers using a lot of these mobile technologies. However, we still have to put forth an effort to find the best way to deal with these things. So it poses some sort of challenge. And in our healthcare environment, there is indeed challenges, or data challenges. A couple of areas that we can look at in relationship to data challenges is data ownership. It is very important, the importance of the healthcare organization to retain the ownership of its data is very much of concern. Traditionally, you would assume that the CIO, the Chief Information Officer, or your lead IT person would be the logical owner. However, there's a difference between data's technical nature and the real purpose of data. A simple analogy would be, say a person stores their car in a full-service garage, and they keep it clean, safe, and make sure nothing doesn't happen to it, and it's always available. But it's the driver who's going to use their automobile, right? So the same kind of thing with data, same principle applies. Your IT is going to be responsible for the physical storage and safety of that data, while the end users are going to be responsible for the quality of the data. So with each healthcare institution or organization, they need to dedicate an individual or a group of individuals the single responsibility of data management. So data ownership is a particular challenge. Another one would be data delivery and translation. A critical skill set is necessary to bridge the gap between data management team's technical environment and its non-technical customers. And so therefore you need somewhat some type of good translator between the two, because you got technical versus your non-technical. So an essential part of your data management role is that of translation. That data management team members need to have the ability to understand what the customers need and then work backward to their data architecture to make sure that data is delivered. Ways that are connected with customers, often clinicians providing healthcare to patients. It includes daily use of what we call KPIs, or key performance indicators. And your key performance indicators, or your KPIs, what they do is measure anomalies relative to your standard performance. So they find different things that's not kind of following your norm. And they can use dashboards, presentations based on the user skills and roles and appropriate data available for ambiguity of your ad hoc analytics. The data needs to be made available to the customer, set in a relatively easy and understandable manner. It needs to be packaged for role-based utility, meaning it needs to be packaged in a way that is sufficient for the person who's going to be using that data. So data delivery and the translation of that is a challenge. We have to fill that gap between technical and non-technical groups who have interest in that data. Data storage is also a challenge. We talked about how much that the volume of data is growing due to this technology and applications in our environment, due to that imaging, that EHR, EMR systems, and mobile communications and devices. Those three elements that we discussed, they take up approximately 70% of the current global data storage. So they are very impactful. They contribute disproportionately to the new data that's coming. They're going to contribute disproportionately to that. Because as those technologies keep becoming enhanced and more advanced, we're going to see more and more data. So we have to figure out how we're going to take care of data storage. These data sources may be valuable in terms of their purposes for having them, but they are difficult to integrate within data storage and retrieval strategies that we have now. The other type of data challenge will be software openness. And basically when we're talking about software being open, we're looking at the challenge of being able to combine or have different software systems communicate with other similarly purposed computer systems. So we need that communication. It kind of flows it kind of alludes to our goal of interoperability, that sharing of information amongst similarly purposed systems. And that's very significant. In order for this to be realized, everyone within that organization or that entity must be motivated to participate in and invest in being open with others. For software vendors, they need to define with whom and what they are open to, who is willing to financially support or mandate this openness, and whether it is a level playing field for all to make that investment. And right now, when you look at the EHR environment, it is an extraordinarily competitive environment, and you see a lot of quick changes in software applications. And if you just look at technology as a whole, just in your personal purchases with technology, we know that is very true. There's always being some changes and upgrades or making things better. Whatever you bought last year is probably no longer relevant or the newest thing out. So we can see that. But what's important here is that we're looking for that interoperability and that communication between systems. Another data challenge is the lack of universal terminology. So what do we mean by that? Well, basically, you have providers who are using highly technical terminology that is not understandable by patients. So one physician may use one term for something and another physician uses another term, and they're talking about the same thing, so that could be quite confusing. So the difference in terminology in our environment is very apparent. Even when we're looking at vendors that build and supply materials for our industry, they also often use different nomenclatures. The nomenclature is like a naming system, right? Even when you look in different locales, you'll see differences in terminology. And all this does is make our goal of data sharing, that goal of interoperability, more complicated. So we need a little more standardization in terms of terminology. So that would be a data challenge. Data sharing, it flows back to what we're talking about with software openness, universal terminology. All those things kind of flow into data sharing. We have multiple ways for sharing data among these different systems that are emerging. You got, and we talked about those different stakeholders, all are like sources of data, and so it can come from multiple methods. You got multiple data sources. You can share share data through multiple methods. However, we need to make sure with that sharing, because a lot of times what we see is all those different silos that we mentioned, and so we will see a lot of things that are not really aligned, some unalignment between these different sharing methods. We see overlapping, and so we have a lot of difficulties, and that all of those types of situations, they can result in substantial data inconsistencies and coordination challenges. There have been attempts made at communication standards like your health information exchanges, your regional health information organizations, your accountable care organizations, ACOs. They're all trying to work on these communication standards. But there is some trouble, challenges, and adversities with these as well. However, with our HITECH Act, our meaningful use in these types of things, hopefully we can work some of those kinks out. The other data challenge here left is your interfacing data within an organization, and we mentioned this earlier on in our course. And basically what we see is you have like large hospitals, and in order for them to function, they run their business. You will see many different software applications that are being ran in their organization. As a matter of fact, you may see 50 to 100 different software applications that are all concurrently running in a hospital to get the job done. However, all these software applications are not fully integrated with one another, meaning they can communicate with one another. And integration is really what our goal is. They did attempt to use what we call interfaces, where they put this kind of we'll go between the different systems and try to make them communicate, but what we really want to see is the integration of the system, which really has to start in the beginning when you are actually designing the structure and creating the structure for these applications. So this proves to be a challenge, and we have talked about this before. So it's going to involve internal software and infrastructure requirements. And you would need modifications on a regular basis. And we talked about hospitals having 50 to 100 different software applications running for their business. Even small physician practices can have multiple software systems for the different functions in their environment as well. So there might be a dozen or more different PMS, practice management systems, software packages being used even just across physicians in their outpatient arena. Now we're going to change a little bit of direction. We're still in the same ballpark, but we're going to kind of focus a little bit more on business and clinical intelligence, or BICI. That's your acronym with that. And when we look at the definition for business, the actual definition for business intelligence and clinical intelligence, basically it's a set of theories, methodologies, processes, architectures, and technologies that transform raw data into meaningful and useful information for business purposes. If we're looking at business intelligence, clinical intelligence, it stems from business intelligence, but we're looking at that for clinical purposes. So basically it's the same definition, but one is going to be for business purposes, and the clinical intelligence is going to be for clinical purposes. One thing we can see here when we're looking at healthcare, BI and CI, it is very subjective. So it sort of relates to when we're talking about, kind of depends on where you are or your locale and how that data is being used. So that in that way it's subjective. And there are thousands of software applications and data elements that are being used daily by your providers, your payers, your other related health organizations, and they all have their own description for what and how data intelligence is relevant for them. And so in that way, we can actually make the statement that BICI is subjective. And there's an infinite number of examples, and I give you a couple here. In terms of a business intelligence example, you can have a CEO, and what they want is a dashboard that's going to refresh nightly. And on that dashboard, they want to see all of their organizations, for instance, their profit and loss data, their accounts receivable, payment denials, all these different things they would like to see on their dashboard that's going to be refreshed nightly. They want to be able to look at insurance payment denials, graphic by hovering over it with their mouse, over that bar chart for, say, Blue Cross Blue Shield payer indicator. Then they can double click on that, and then it drills down into some more details for the claims. And then they can tag those in a detailed report that they can send off to the CFO with some appended questions and a request for response on that situation. So you can see how this can bolster the CEO's ability to be more effective in the job that they do. That's a business intelligence example. In terms of a clinical intelligence example, you can have the purchasing director sitting in a conference room, say, with a pharmaceutical rep, and that pharmaceutical rep is trying to propose certain items, maybe for the surgical team, and they want them to purchase maybe some things like some disposable surgical items for them. Well, that purchasing director can have his laptop, and he can go into his clinical information system and look at certain things in terms of the surgeon's things that the surgeon needs. Maybe look at a count, a cost, the shelf life of some items, what that surgeon preference is, all in a pie chart. And then he can compare those metrics that he's pulled up on that CI system with whatever that farm rep is proposing, and compare it to, and it will supply him with the information he needs to make a decision on whether he wants to purchase what that farm rep is proposing. So that's a clinical example, CI example. You can have another example where you integrate in the BI and CI. Say you have a clinic administrator, and they're trying to negotiate a contract with an insurance company where they're trying to insure their employee population. So that administrator can go and search their BI/CI data. If they're talking over with this insurer who's trying to get their business, they can pull up BI/CI data for their employee population who's currently in the practice. They can sort that list in several different ways, depending on what their interests are. Say maybe they want to do it by diagnosis, by age, by weight, any of the above, in multiple formats. The administrator can produce that same type of summary for 3 other pairs, a large employer contract, and then do a comparison. So the whole gist of these examples is, if you can see the thread in them, they have information that they need to make effective decisions at their fingertips. So that's basically what we're driving at when we're talking about BI/CI and the data. We got the data we need to make very educated, effective decisions, and that's going to produce desirable outcomes. That's the whole gamut of any of those examples, and why it's important, why we want this type of system. Now, some other things to note here about BI and CI is that there has been mixed experiences in terms of successes with BI and CI. It's many different components that kind of weigh in to that. And one thing in the figure that you see here, what it is pointing out or driving home, the concept is driving home, is that there is an actual correlation between those people who use BI and CI and analytics with the complexity for creating the content. So in other words, you have the larger number of users who are at the bottom of this triangle. The uses that they require are more mundane, are more easily created content. So you got a higher number of users versus those at the tip. They have more complex needs, and you see there's only 5% of those who are actually utilizing your BI/CI intelligence and analytics. Really, your clinical intelligence concept is a more recent one, but it's in conjunction with our increased adoption of our electronic health records, our electronic medical records, and our personal health records. With the increase of those, we start seeing the terminology and the concept of a clinical intelligence kind of come about. When we properly implement a clinical intelligence system, it's going to support a more focused clinical analysis, more so than your business intelligence. But if it's designed and managed correctly, it will integrate that business data alongside that clinical data. So BI/CI adoption in healthcare organizations have pretty much been very slow. And we've talked about different issues like those siloed application environments that we see, those different separate repositories for data that we see inherent into these organizations. And so they're not really providing a holistic, comprehensive viewpoint due to these things. And so in actuality, it deters the progress. Cost, limited experience, restricted implementation resources, numerous mandates and industry requirements, and a host of other different things are actually valid reasons why BI and CI have ended up being a lower priority than other efforts. However, when they survey your different organizational executives and different member groups like HIM2112C, stands for Healthcare Information and Management System Society, when they survey these groups, they indicate that they do plan to become proactive with projects like BI and CI. In addition, when we look at our current crisis in terms of cost and quality of healthcare, we will gain a lot significantly. It will benefit us to have this BI and CI intelligence or capabilities. Let's look at the history of BI and CI. And a lot of this we may, well, some of it we may have mentioned before. But one thing we can note is that we have come a long way in terms of data collection and processing. When we were in the late 1960s and the early 1970s, healthcare-related data was generally focused on your billing, as I mentioned before, and your insurance claims. You had what we call a fee-for-service reimbursement, where they pay after the services. It was pretty much straightforward. Your adoption rate for computerization was pretty slow because it required a significant resource investment. But as we saw transactional software come on the scene, it began to capture data that was sufficient for providers to file claims and for payers to adjudicate those claims. And so we saw the art of functional reporting start to emerge. Right? That reporting became part of the promise of your health information system through the advent of your early healthcare software. But what you saw in terms of these reports was like limited tabular screenshots, and so they weren't really the most efficient. The other thing with these reports, they amplified the friction between your payers and providers who were arguing about who should have what money and when, right? So they, it kind of exacerbated that problem. You really had most of your data processing directors with this type of reporting. Most of the time was spent trying to make sure that their system didn't crash versus using the information. So that also wasn't exactly desirable in the early days. Your reports were typically structured or what we call canned, meaning it's just one way, one setup. And so any request for changes to a report, they just would queue those or put them in a waiting area for enhancement, because it was not an easy task to make changes to the canned or structured report. We didn't have very many software offerings available. And so they would produce these reports for specific applications and for specific audiences. Then over time you start seeing the spreadsheet overtake your report as an analytical tool. And during the early days of computing, multitasking software and PCs weren't available. The terminal screens, they would be gray or orange or green in color. You would have these large computers that were operating on slow phone line connections. The programmers were using languages like COBOL, Fortran, and Mach to manually program their report. So when they wanted to include data that was not already pre-planned, or data later on after that that report was programmed, it was not an easy task. And to boot, they did not have email or the internet or networks available to them. So that was really something in terms of trying to get something done with those reports. Then in your mid-1990s, let me click that. Then in your mid-1990s, you had your EIS, your Executive Information Systems, and your DSSs, your Decision Support Systems, came on the scene. And what they did was brought together data from your multiple sources and assisted management in making decisions that was relevant to providing that care for your patients. And that data was coming from those different transaction systems that they had. At that point, your BI effort was still kind of static, but they were making progress. However, the report that it was producing still took a lot of time to produce them. We started seeing some analysis for limited clinical measures coming about, but it was mostly for internal knowledge. Your payers wanted more information. They started requiring or demanding more information at this point, but it usually was very narrow in scope in terms of what they were asking for. But all of these efforts were limited because of the computer power that was available at the time, and then you had constraints associated with the older type programming languages that they were using to create the things we were trying to benefit from. You also, at the same time this is occurring, you had a political focus on the rising healthcare costs, right? But this opened up the way for our early EHR systems to come on the scene, for us to find ways to increase our computing power. We had internet technology to come about, and then less expensive data storage was available. I already mentioned early in the presentation that there is a great deal of subjectivity in the delivery of healthcare for BI and CI. Almost every application that's out there that's available, you have a handful of leading competitive systems that are trying to vie for customers in different niche areas. You got a lot of proprietary systems. You have disparate vendor software packages, computer configuration strategies for IT and business management. You just got a host of different type things available trying to do the same thing. And so there are a lot of inefficiencies and confusion in terms of the landscape of software and the way we deliver those different delivery methods that are being utilized in the healthcare industry participants, by the healthcare industry participants. There are several major reasons why your healthcare analytics can be a challenging environment. For one, we mentioned how fast healthcare cost is growing. It's and how they projected it to be 20% of our GDP in 2020. So that's not a good thing. So that can be challenging. There's not very much financial incentive for coordination of care among different competitors. They're trying to hold on to whatever that competitive edge is, and they are not very motivated about sharing information with other competitors. We have more than 3 million healthcare providers of various types of services in the United States. So we got a gamut, a wide, broad scope of different types of healthcare providers. There are more than 6,000 hospitals, more than 200 insurance payers, there's 141 medical schools, more than 16,000 nursing homes, all doing the same thing differently. And we talked about that, so that can prove to be a challenge. We got dozens of legacy programming languages and operating systems still in our healthcare industry. We need to address. There are more than 1,000 commercially sold homegrown software offerings for healthcare practices, different types of EHR, EMR, PHR solutions. We were just talking about that. Just a lot of different, varied vendors. We got several communication standards that exist, so no one universal standard for communication amongst these technologies. You got the laws and your different things that affect our data elements, our functionality, security, interoperability, requirements, interfaces, operational use. So you got different, and they're always changing, so that makes it kind of challenging as well. Public health and population management access to non-governmental health delivery is limited. All these things contribute to what we can arguably say is a challenging healthcare environment. However, despite these hurdles, we have to use our data to help solve and improve all the facets of the industry. So we can't use that as an excuse not to get things done. So now let's look at some models for enterprise architecture and strategy that may help lead us to better analytics. There are some terminology that's used in, when we look at the critical components necessary to find a usable analytic solution. One thing is, you may hear is the terminology source data. It's your operational or transactional software applications that are used as a point solution and serve as a multi-purpose solution for different functions in your organization. That data enters through an application, the application's operational use, with those data then becoming available for subsequent extraction to a central data depository or a BI/CI system. So basically, in other words, we are talking about where that data comes from, those transactional activities that we're going to use to serve or fulfill our BI/CI system, our central data repository. Another concept is that of extraction, transformation, and load. You may see that acronym as ETL. It's a generic term that is used more than just in the healthcare industry, and it refers to the process for creating data repositories for analytical purposes. So it starts with a software application in which we have entered some data. That data then can be formatted for extraction. So that's the extraction part by a third party. Then that data that's being extracted is going to need to be transformed. So we got extraction, transformation. All right. The source data may then be imported or loaded into whatever our target repository is, which is typically some type of BI/CI system or another type of application software. So that's what they mean by extraction, transformation, and load, ETL. Metadata is basically data about data. So in other words, your metadata is going to identify where your source data was created, when that source data was created, who created that source data, and for what purpose, where that source data is located in the computer architecture, and where the standards was used when we in that data creation process. So it gives you data, information about your source data. That's what metadata is. And we keep using that term Central Data Repository, or CDR, and it basically is sort of similar to a data warehouse, and it stores large amounts of information. It can replicate that data from your source system and then organize that for the purpose of analytics and assist with disaster recovery. All right, so it's going to support, help that system replicate that information and rebuild that data in case it somehow is that original hardware is destroyed. So that's what a central data repository is and does. And we've already talked about your BI and CI, and they are pretty much synonymous with, when we keep saying analytics, it's synonymous with analytics. We know, we went over what those, the definition of those are. Then you got your utilities and your rules. When you have an IT system, you have administrative utilities and rules. Basically, your functionality for all those, your reporting, your dashboard, your clinical indicators, and everything are programmed in those utilities. Now, from there, let's kind of segue over to looking at requirements and functional attributes for having a viable BI/CI system or solution. One thing we have to be concerned with is security. All our data needs to must be secure. Each data element should be ensured that it's secure and limit the access and use and improper exposure of those elements. So they can tag those different elements, and this will assist in providing an audit trail. And you know that is a very good functionality when you deal with your automated type technologies. You have extensible and scalable. That's a requiring a function attribute of a BI/CI. When we talk about extensible and scalable, that means that solution, that BI/CI solution, must be able to scale up and move into new areas when needed. So it has to be able to expand, and it may require more data to be as they are developed. So it has to meet the increased demand for the future. All right. Integrity. It deals with well, when we look at the healthcare arena, and we're looking at BI/CI, there is always a level of subjectivity and variability, and we already talked about that. But alongside that, there is a great emphasis on humanity because we're dealing with patients' health. So from both of these vantage points, accuracy and integrity is going to be imperative. Your users have to be able to trust in that system, which increases our need for integrity. Performance. Your systems need to be able to provide real-time information to assist with clinical decision-making. That clinical decision-making is going to depend on that information or that output that it receives. So that output needs to be timely. It must be readily accessible. It has to be responsive. So that is a very important functional attribute of a BI/CI. And so accessibility, as we were kind of alluding to in the performance area, we want to be able to do our job effectively in the healthcare environment. And so that information needs to be accessible. That BI/CI system has to be properly designed to make it relatively easy for those who are trained to use that information or who are authorized to use that information to access it. Usability is going to be important. One reason for the relatively slow adoption of these BI/CI solutions is that many are still rather complex to use. So usability is going to be important if we're going to realize the benefits of a BI/CI solution. We have the system has to be built and modified for non-technical personnel. And this is going to have a greater likelihood of success, and we talked about that before. Your BICI solution needs to be actionable. If a BICI solution is not actionable, or in other words, does not improve decision making, enhance day-to-day performance, solve relevant problems, or improve processes, then we more than likely are going to discard it. So it needs to be actionable. It has to be clear evidence that person feels, so that person will feel comfortable in using it, managing their functions, changing methods, doing their work, making decisions with that BICI solution. Asking from the answers is another attribute. Basically, once you have a BICI solution in the hands of the workers, they may know better what kind of question they need to ask. You know how sometimes when somebody is describing something, you may not have a question until you are working with that solution or that problem or whatever we're looking at. When we have a competent analytic solution, it will allow an inquiry's answer to be queried time and again. And you may not know what your next question is until you see the answer to the first. So this is what we mean by asking from the answer. It becomes a circle of investigation based on digging and creatively using stages for analytical output. Role-based use, another functionality. Every employee has a particular role that they fill, and so in every worker is going to need some level of actionable information in order to perform their job or their role. For example, your executive, they may want to have some type of sweeping view or broad view of different strategic business operations, but also have the ability to drill down into highlighted areas of concern into a more detailed level. And so therefore, based on roles, you want to have your BICI solution to work in relationship to that. Dashboards, we kind of did an example about dashboards. Your dashboards allow your data set to be graphically presented. And they can access them on a regular basis, and they can toggle between information using your mouse. And so what the idea behind that is to centrally locate lots of information, and they can do a summary level view, and then they can click on certain areas and go down to a detailed level view. And then finally, the retrospective nature of BI and CI. And basically this is referring to them particularly updating your clinical data repository or your BI solution. And they typically do that on a daily basis. Therefore, that analytical reports, the dashboards, and other outputs are generally produced for the various users the morning after systems have been updated on the prior evening. And this gives your end users data to inform decisions going forward in the new day. And so that's what we are talking about here about retrospective nature of BICI. Because you got those real-time clinical decision making that needs to be done. And so we have to address how we're going to update that information. This is going to conclude my presentation on data, business, and clinical intelligence.